Hi, my name is Carrie Lin. I am an intern at the University of Arizona College of Medicine, Phoenix. I wanted to share this case report about psychosis and catatonia in postpartum patient today because it was an interesting case to me that I learned a lot from. I worked with my attending Dr. Petty to put this case report together. So first we'll start off with a little background information. Postpartum psychosis is one of those big things we learned about in medical school to look out for during the postpartum period. Studies estimate that it occurs in about 1 to 2 per every 1,000 births. Most commonly, it's found in women with bipolar disorder, about 37%, but can also frequently be associated with MDD, schizophrenia, and schizoaffective disorder. The unique part of postpartum psychosis is that it can present like delirium with this waxing and waning pattern. Moving on to a little bit about catatonia, this can be seen in about 10% of patients with acute psychiatric or medical illness, frequently infectious, metabolic, and neurologic disorders. Catatonia often goes unrecognized and can be pretty difficult to identify. And importantly, catatonia can be exacerbated by antipsychotic medications. So this is a case of a 42-year-old G5 P0323 female with no past psychiatric history who's 6 days status post C-section, initially presenting to OB triage due to some anxiety after visiting her newborn in the NICU. They discharged her on 25 milligrams of sertraline for suspected postpartum depression, but she returned 4 days later for worsening mood and psychosis. They had reported that she had fears that Walmart was trying to kill her, that she couldn't move her body, and had been having falls. But of note, she was able to walk into OB triage on her own without assistance. And she had some insight into the fact that her paranoid thoughts were irrational and not true. Her sertraline was discontinued due to her worsening mood, and she was offered inpatient psychiatric admission, but she denied any SI, any HI. She wanted to just go home and follow up with outpatient care. The next day, she returned to the emergency department with worsening paranoia and hallucinations. She was making statements about how her baby was dead, and if she stood up, she would also be dead. In the emergency department, she was given 2 milligrams of lorazepam for her paranoia and agitation. The psychiatric consult team evaluated her, and she agreed to go to the inpatient psychiatric unit. On arrival to the inpatient unit, I meet her. She's pretty somnolent, but is able to tell me that she just feels confused, and that her paranoid statements were just jokes. I spoke with her husband, who confirmed that she had delusions that everyone was dead, her dog was possessed, and she was targeted for causing COVID. He had also mentioned unusual behavior at home and that she had distanced herself from family, stared into space during conversations, and pretty disengaged overall. So we started her on risperidone, 0.5 milligram BID, but didn't really notice any improvement. She was continuing to worry about her baby and thought her baby was in another patient's room and that patients were mimicking her. The risperidone was increased to 1 milligram BID, and this is when she started showing symptoms concerning for catatonia, including psychomotor retardation, poor eye contact, hypoactivity, poor oral intake. Her Bush-Francis score was 15, scoring in immobility, staring, automatic obedience, withdrawal, impulsivity, and perseveration. At this point, the risperidone was discontinued, and she underwent a 2 milligram lorazepam challenge. After about 45 minutes, we reassessed her, and her Bush-Francis score was 4. She was then stabilized on lorazepam 1 milligram TID with complete resolution of catatonia and psychosis. She was discharged from the inpatient unit with follow-up with outpatient psychiatry. So in retrospect, there are a few points during this case that pointed to the diagnosis of catatonia. First was her behavior at home. She had been distancing herself from family, staring into space, pretty quiet overall. This was initially attributed to more of a postpartum blues and depressions kind of picture and treated with sertraline, but this may have actually been the first indication that she was catatonic. Next was her response to lorazepam in the emergency department. When she was admitted to the inpatient unit, she was sleepy but really denying any paranoia or hallucinations that were previously reported. We had attributed this to the waxing and waning nature of postpartum psychosis. And then there was her decompensation with risperidone, which is a key identifier of catatonia. So overall, catatonia can be difficult to identify in patients who are presenting with acute psychiatric illness, and even more difficult in the setting of postpartum psychosis due to its fluctuating presentation. It's important to suspect catatonia early on, especially in cases like this where we're planning to treat with antipsychotic medications. That way we can prevent any exacerbation of catatonia and promptly treat her appropriately with benzodiazepines. Here are some resources that I found to be pretty helpful while treating this patient and while putting this case report together. Thanks for listening.